and women's issues, and also about nurses. And it's certainly sharpened my ideas about and my passion about women. There are 4 points that I'd like to make in this conversation, in my conversation with you in the time I have. I will share, you're lucky I'm not going to be talking about transition today, although I would love to talk about transition. The other topic I would have loved to talk about is against the DNP. But lucky you, I will not be talking about either of those. I will share with you my journey that made me passionate about women's health. And I will, secondly, I want to convince you that we should not talk about women's health. We should talk about women and health. And I'll tell you why it should be women and health rather than women's health, and rather than just talking about maternal and mortality infant rates, mortality rates, morbidity rates. I will discuss other ways to look at progress, and moving forward, I will share with you the recommendations that we published in the Lancet report, which I hope everybody has read. But I will share with you some of those recommendations, and I will suggest some areas of research and investigation. But talking about progress, I am so excited that we are finally going to have on our money, on our US money, we're going to have women's pictures on them, finally. And what I'm really excited about, too, is that 4 of those women had a relationship with Philadelphia, either came from Philadelphia or escaped to Philadelphia. And the first one up there, Harriet Tubman, born a slave in Maryland. She escaped to freedom through underground railroad, traveling nearly 90 miles to Philadelphia in 1849, and she also was a nurse. So that's really important. That's part of the progress I consider related to women's health. One thing that we know that women who are healthy throughout their lives have lived through equality. They were enabled, they were empowered, they were valued in their societies, and their roles as caregivers were acknowledged and valued, and that helped them achieve their highest potential. So if we know that, then we really want to make sure that women are as healthy as possible. But here is what happened. We had the MDGs, which we have been hearing about, and it's true there are 45% fewer maternal deaths, but 800 women still die daily from preventable conditions. There is 1 in 3 women experience physical or sexual violence in the world, and 133 girls are still circumcised in 29 countries. And I think this is really important to remember. 50% of women work and wages that are 10 to 30% less than the same job that men do. So that there is no equal economic compensation. And more importantly, 22% of women make up parliaments in the world. So only 22%, and we are 50% of the population. And of course, whenever there is a disaster, and there is one in Haiti right now, and there are disasters in the world, women are the ones who are spend the time taking care of the aftermath of disaster, and they carry the water, and the girls carry the water, and therefore they are not able to go to school. So after the millennium, and of course women in the United States are significantly worse off than women in 16 other countries, which is waking us up in the United States to realize that even in developing countries, women are actually marginalized and deprived of really good health when compared with other women in 16 other developing countries. So the 8 Millennium Goals, we had a bit of impact, but we have not achieved them. So as you heard this morning from Annette, a really fantastic presentation. We learned a lot from that presentation and what WHO is doing. There are the Sustainable Development Goals, and it's true, there is one of the goals, the 3rd goal, that is related to health, but all these other goals are very much related to women and what women's health is about. And that's another presentation that I love to make. But I think what's really exciting about the Sustainable Development Goals, and I think every student and every faculty member should study the Sustainable Development Goals, and we should make a contribution as nurses with very strong voice, because nurses, as we heard today from Dr. Annette, that we are the biggest force in the world, and we have to have the biggest voice in the world too. And so it's really about sustainability, and sustainability means that we think about development, economic development, environment, and social development without jeopardizing or undermining the future of our grandchildren, our great-grandchildren. So it's how do we develop and actually continue to make sure that the future generations are also benefiting. This conference is about research, and we heard a lot about research, and of course we do need to do research. However, I want to remind you that it's about knowledge. It's not only about research, and I think we heard a little bit about that in this previous panel. It's about experiences. It's coming from a feminist perspective, and from a feminist perspective, it's about gender experience in our countries, in its totality. It's about critical knowing. Postmodernism tells us something else about what knowledge is. And we have to remember the four corners of knowledge that were published in 1979 by Carper. We know through ethics, we know through our personal experiences, our clinical experiences, and we know through empiricism. But empiricism is not the only way we know, and therefore we really need to be talking about some of the other ways of knowing, which would be socio-political knowing, and a sixth way of looking at it, as Peggy Chen reminded us, is by reflection on actions that we do. And nurses are about actions, and nurses are about practice. So how do we establish truth? How do we establish truth is a question that we all need to be asking. Well, I think many people would say we establish it through sensory data and received view and empiricism and data and counting. But there are other theories. There is the coherence theory, which is the logical development of an idea, the building of an idea, patterns, and we nurses are about patterns. We look for patterns of behavior, and we determine where does the person fit in terms of their history. It's also about experience, and it's about influence. That's how we establish truth. We forget that in our journals, and we think it's about only the first one. But I really believe that there is an integrative approach to knowledge, which takes diversity of views. And let's not forget that, and let's honor and value that. So with that introduction that brings together my interest in epistemology and theoretical development of a discipline and research, I want to tell you where my passion about women's health has come from. It came from a number of sources, and it came from my practice. It came from my practice as a nurse, watching women coming into our healthcare system, watching what happened to immigrants and how they are marginalized and how they are treated, becoming mothers, becoming fathers, becoming acutely ill and taking care of a spouse who's acutely ill or chronically ill. Even watching students observing nurses coming into programs and coming out of programs, and moving from intensive care. So these are all the experiences that alerted me that to women and women's situation. But it's also about research. So let's not forget how important research is. So very early on in the 60s, I studied family planning. And I started by asking the question, Why aren't women effective in planning their families? And I found out that this was actually the wrong question to ask, that it's really a family affair. It's interaction. It's how women feel about themselves in a relationship, how empowered they are in their social structure, that I can't only study women by themselves. I need to study how the rest of the family view women. And so I started thinking about women's experiences and family, and that it's not only women by themselves. Then with Dr. Kathy Drake, we did a series of studies about how the health outcomes of patients who have undergone a cardiovascular event and what helps in their rehabilitation, and found out that effective interactions between partners, particularly women in the family, and engagement of women in the rehabilitation were very important in the outcomes that we found, which we wanted to find at the end of rehabilitation. Increased weight loss, decrease in blood pressure, decrease in smoking, and so forth. That those outcomes actually happen because of the engagement of women in that care. That alerted me to the caregiving of women. So we took it from there, and with a group of my colleagues, we studied women in 11 different countries with in 5 countries, 11 different populations. We focused on women, low income and no income women. And we wanted to look at the health outcomes. Socioeconomic situation was really important, was a very much determinant of health, and I'll tell you some of the findings from that led then to where we are right now and how we define women and health. But then I went to Kuwait, and I went to Kuwait for a couple of years, and I thought, oh my goodness, with all this oil and all these wonderful opportunities that are open for women, and educational opportunities and work opportunities, situation for women must be so fantastic, and their health is really progressing and meeting what it is, the level of wellness. Well, but what I didn't know then is that even modernization, we need to look at it from a gender perspective, because it's true it has more opportunities and better education. However, there are traditions, there are customs that prevent them from really achieving their full potential at work and their full potential in education. Societal changes affect women's roles, and women's roles affect their health and well-being, and affects the mortality rate and the morbidity rate, which we need to look at. We need to look at carefully. Then we studied immigrants in California. And we found out that because they are disconnected from their support system, which would have provided them the opportunity to a sense of wellness and a sense of ability to process some of the stressors that they are going through. But that disconnection, because of the immigration experience and because of the double stresses imposed on them by their family to make sure that the children are following the traditions and the customs and the norms that came from their mother country, but then the pressure of us in the United States that put on them to Americanize them so they can be mainstreams and respond like everybody else. So those women suffer tremendously and from inequitable treatment and increase in their stress. So it really brings us to many of the things that fine presentation that has been happening, that people are affected by the political system, but I say women in particular are very affected by political system. Contraception comes and goes, paid for, abortion accepted, not accepted, access to health care. The political systems determines whether there are benefits for women or no benefits for women, and all kinds of demographic population growth affect women. And of course, it's not only the infectious diseases and Zika that we are hearing a lot about now, but it's the non-communicable diseases that are because women are moving more into urban areas. So I think any of those transitions are, we need to look at the transition, the economic transition. We are very happy about new jobs, but there are gender gap in wages. Their elderly care is suffering, and we know that women are living living longer. There are the environmental disasters. That's one of my favorite, because when we see what happened with the tsunami, for example, and how women who were wearing saris tended to die more because they could not, they were swept away with the tsunami far more than men. So any one of those situations need to be studied and looked at from a women's perspective. Even urbanization that we are really proud of. There is increasing urbanization in the world. And people are moving into urban areas away from rural areas. What does urbanization do? It makes women far more vulnerable. By 2030, 70% of the world will be urbanized. And 70% of those people who are poor in these urbanized areas are women, 70% of them. The physical capital puts them at disadvantage, because, and we as public health nurses, we say you have hypertension, you need to get out and walk, and you need to exercise, not thinking about there are no lights, it's not safe in that environment, and we say, how come you are not coming for your appointments? Well, with urbanization, there is increase in density, there is less planning that's done by women. That's why with my colleague, who is the director of the Center for Urbanization, we looked at the number of women who are involved in urban planning. The view of women in urban planning is not well represented. So not only do women become vulnerable because of urbanization, but they are also vulnerable because their views are not really reflected in the urban planning. Communities without strong ties, and this is women come from rural areas or come from countries with strong ties, and they come to an area that does not have those strong ties, and we know that without strong ties, the areas are very much unsafe for women. No place to really get referrals, to talk with each other about what's going on with trafficking and violence. But the risk factors are not only those risk factors. There are increase in tobacco use. There are for women. There are increase in alcohol use. But when we looked at the risk factors for non-communicable diseases for women, another interesting thing hit us right in the face, which we have in this publication. We found out that there is very little data about some things that are really important for the determinants of health. The physical activity that we say how important it is. When we looked in different countries about women's physical activity, we couldn't really determine whether it was enough or not enough. When we even looked at infections, all kinds of infections, there wasn't enough data. The respiratory diseases, so it really surprised us because we looked for the data and we thought it's there, which is saying we do need more data and we need more research, and nurse scientists, nurse researchers need to be doing that kind of research. The disability adjusted life years is not only when we look at it in terms of women and how it's affecting women, but women take care of men in their lives. They take care of their parents, they take care of their spouses, they take care of their children. And so disability adjusted life years that we have looked at, and we said there are really no differences between men and women, are really not good data, because we haven't figured into it the disability adjusted years of their spouses, usually men, and they take care of that. So I think that brings me to that there are so many demands on women, far more than their reproductive health. Yet when we think about women's health, we think about reproductive health. It's not only their education and the societal traditions, but it's the demands that come from spousal care, the emotional work that women go through in their community, in the peacemaking and the integration into systems. It's women who integrate children into school systems. It's women who integrate their families into the healthcare system. And I'm glad to see that more men are doing that now, and I'd like to see it that it's 50-50, and maybe you are moving to that. And let me tell you, I have 2 sons, and I make sure it's 50-50 in their families, and they really are 50-50. But women are responsible for extended family. So what we need to do, and that's what we did actually in our studies, we asked how do women maintain their health? What strategies do they use to function in different roles? These are really still very, very good questions that we need to ask. We said you have to explore their lived experiences. We have to study the nature of their work. We have to study the nature of the work that women do. We have to identify the stresses and satisfactions, describe their health concerns, and identify the predictors that way. And these are very important in really understanding women. So from all these studies, what did we find the risks for women? Really surprised us, some of the things we found. We found that they talked about unchallenging work. They talked about the fact they have no authority in their work. They talked about poor pay. They are constantly searching for economic and social security. They feel exploited, staying in relationships that are abusive, staying in work relationships that are abusive, staying in nursing situations that are abusive, and whether it's real or perceived. They feel devalued, and they feel there is a lack of support in general. But one thing that really intrigued us was there is something called the work of worry. They are constantly worried about, is the bus going to come in the morning to take me to my work? Because if I don't get to work, one day is going to be cut out of my salary. Will I be able to take a day off because I have a health problem? There are constant worry, and they feel very marginalized. Now, these are adult women. However, this is also true for the girl child. And this is the group of girls that we call them adolescents, we call them teenagers in different countries, but they are lost between pediatric and adult care. And I was in Cuba, and I met Dr. Marcela Torres Esperon, and I think she spoke here yesterday, and I don't know if she is in the audience, but you know, I was so impressed with the booklet she produced to empower girls. Oh, yes, you are. Here you are. Thank you for the booklet you produced to empower girls and boys. And I think everybody should read that book and should use it. But the girl child is lost, and there is very little about the girl child. The leading causes of death for the girl child is self-harm, maternal disorders, road injuries, and most important risk factors for them are intimate partner violence, anemia, sexual abuse. And they are more vulnerable to get into alcohol and for tobacco use. They are a real wonderful audience for that, and they absorb it. And of course, we know a lot more now about trafficking and slavery. Slavery and servitude. The early marriage for girls, that's also servitude, and that's the parents are doing that for their children in many, many parts of the world. So I can't tell you how important it is for nursing as a workforce to focus on this group of girls that usually are not part of our studies as much. And they are deprived of education, and we know that education actually increases the health of girls and women, and of course they have the risks of pregnancy and sexually transmitted diseases. But you know, aged women are not immune either to some of the discrimination and the marginalization. Women are living longer now. They take care of their spouses, they take care of their parents, they take care of everybody in the family, and then because we have the constitutions that keeps us alive a little longer, many women in many countries I have been to who are elderly women are left by themselves, and we don't have a real plan for their care. There are different models, but there are real plans. In the United States, 1 in 6 white women live in poverty. 1 in 3 African American women live in poverty. 1 in 2 Hispanic women live in poverty. That is stunning statistics for the elderly population. So now, I talked about practice experiences that have been really important in making me passionate about the situation of women. And I talked about research that got me to this point. But I have something we all have that in our life, our own personal experiences. Where did we get to study whatever it is we studied? I think grandmothers are very important. One of the earliest models for healthcare of women is the one based on grandmothers' insights and caring practices. And whether grandmothers know it or don't know it, they provide their offspring with the first framework of how women's health is viewed and dealt with their families. And in case you're wondering about those three people, that's my mother and my grandmother with me. And you can see the change in clothes over the years. But what I owe a great deal to my grandmother, who never went to school and was a farmer, moved into urban areas to be with her daughter and granddaughter, that's me, because she knew how important education is. She sacrificed to make sure that her daughter got educated. But I also learned about her having her own babies in a rural area all by herself, and cutting the umbilical cord and carrying the baby and going back and to farming. So I learned about access to healthcare, lack of access to healthcare. I learned about her views of circumcision of girls from her perspective, which is very different than the perspective that we study and we hear about. And it made me respect the different perceptions, and it made me respect the fact that I've got to get to the lived experience of people, ask them about their life history to really understand them, value them in spite of the fact they might not be educated or might not have the same value system as I am. So family, I'm just sharing those with you to tell you that where I started my passion about women's health was in my mother's clinic. She was a midwife, and I used to sit in that clinic and listen to women's stories and girls' stories. These have influenced me a great deal. That's why I talk about knowledge and not only research. You develop passion about your area that you want to make a difference in when you really dig where does this knowledge come from. But I also, my passion about women's health came from the challenges that nurses face in the world. As we heard this morning, nurses are the largest providers of health care. 90% of nurses are women. It used to be 100%. I'm really proud. We are recruiting far more men in nursing, and I look forward to the day when 50% of our workforce in nursing are men and 50% are women. But for the time being, nurses are mostly women. Nurses and midwives, we heard this morning from Annette, are instrumental in meeting maternal and infant health MDGs and C and Sustainable Development Goals. They are there are 20 million of us in the world. Where is our voice in taking care of 77 billion people? There are 20 million of us. Nurses are not allowed to practice up to their full capacity in many countries, in spite of their education, including in the United States. And 60% of all workers are informal workers, undercompensated or uncompensated, and without any benefits. 2/3 of women in low, middle income labor markets are informal workers. Insecure employment, limited control, and access to health. Notice I'm talking about women and health, and I'm including nursing workforce in it because we've got to include it. We can't be providing the quality care for women unless that quality care, we are also recipients of that. We know that more educated women are healthier women, and if they are healthier women, their families are healthier, and their communities are healthier, and there is resistance to violence, and there are more safe environments. Put that nurses, more educated nurses, they are more healthier nurses, and as we heard yesterday from Dr. Eileen Lake, that the healthier the environment for them, the healthier they are, the better care they are provided. So nurses as the largest providers of health care. What do I hear from my colleagues internationally everywhere I go? Of course, history is changing a bit. There is limited investment in educating girls, women, and nurses. There is a pattern there. There is a pattern. And the pattern applies to nurses, applies to women and girls. Women as informal and formal caregivers, not appropriately compensated. And definitely nurses, educated nurses, are not allowed to practice up to their full capacity. That's where my passion about the changing situation of women comes from. But in addition, there is a long history of talking about women and health. And we have to look at that history. And we have to honor it and learn from it, and our students need to know that and need to use it. It started from the first International Women's Day, 1911. Birth control came in 1960. The interest in women specifically was established in 76. There is the UN Decade of Women that was established in 76 to 85. A day was designated against violence against women in 81. Safe Motherhood Conference in Nairobi called for, it should have been safe womanhood, but it called for safe motherhood, and that we've got to do something. It's not only infant mortality rate, and it's not maternal mortality rate, but it's more than that. Have mothers be safe as women. And there are activists against gender-based violence. And then there came the Cairo Conference. Cairo Conference was really important. It came after it. The Beijing Conference, this is where Hillary Clinton said, human rights, women's rights are human rights. And we began to introduce, each one of those events introduced a new framework to women and health. And the MDGs came in 2001. And definitely the MDGs honored education, how important education for women, primary health care, maternal and infant mortality, empowerment of women came in the MDGs. Finally, some words that really reflect women. Of course, I have to say that this was an important event. And United Nations established an office called UN Women. This is very important, people, to really think about that, because before that, women were sort of normalized in all institutes until women said, we've got to have a section for ourselves that really focuses on women and tracks what's going on with women. And I'm really proud of United Nations because it's established in October, the International Day for the girl child too. So, lots of things that are happening that really brings us to where we are right now that we need to study. What puts women at risk? It's not Zika, and it's not typhoid, and it's not malaria. It's the gender divide. It's the gender divide that is in every aspect of what we think about. It makes women socially, culturally, and biologically at higher risk for morbidity, for mortality, for inferior quality of life, for a disproportionate burden of the disease. And you add that to any one of the diseases. The gender divide creates, although women are born with a biological advantage, but they inherit through the environment and through the gender divide and through being marginalized and through being devalued in terms of their work. Women are the informal caregivers, and as I said, 60% of workers are informal. And I repeat that because that's really important when we come to think about compensating women. But in addition to all that, contributions are devalued. It's wonderful. Women are valued for being good mothers and they are good caregivers. But that valuation doesn't come with compensation, and it doesn't come with benefit. It comes more as expected and accepted. That's what women should be doing, and that's what women in all professions should be doing. There is unequal compensation, and there are inequities in healthcare of minorities, and particularly women. So what we did with the Lancet report, we had two economists, and we said, okay, we have given so much lip service to inequities and to the fact that women caregiving is not compensated and nurses' work is not compensated appropriately. Could you study that, please? Could you find out what it means? And what they found out that actually they studied in about a dozen countries women's contribution and found out that the total value for women contribution to the GDP is about 5% of the GDP of countries. And we know that economics are really important, and we know that when people make money, they are called productive, and they are adding something to society. So 45% to 57% of women's work is underpaid. 45% to 57% to women's work is underpaid. Nurses enter into that, but this is just in general about women. So there are multifaceted pathways through which women and health interact, moving beyond the traditional and exclusive focus on women's health to address women's work, to address the roles of women, both as users and as providers of health care, and highlighting the potential for synergy between them is what's important. If we talk about women's health, we really should not have the narrow definition that has been, it's a barrier to health of women. There is a narrow definition of women's health that we need to get away from. There is a lack of coherent framework. There is a narrow focus in education of health professionals, and there are policies and laws that undermine women's work, formal or the informal sector. So we asked the question, we said, what would women's status and situation in the world be like if societies valued their caregiving roles, acknowledged their not-for-pay work, supported their role juggling, and provided them with the resources for their complex repertoire of responsibilities? What would these societies be like? What women's status would be like? So a group of us from 13 countries, including your ex-Minister of Public Health from this country, from Mexico, Julio Frank, came together as a commission, and I co-chaired that commission with Dr. Anna Langer from Harvard. And we looked at all this data, and we looked at what recommendations we would make, and we said that we have to address total life cycle of women and the circle of giving and receiving. The circle of giving and receiving that include nurses as giving and receiving the care, and they are women. And we developed a framework. We developed a framework that, because there isn't a coherent framework, that is based on gender equity, gender equality. It's based on human rights. And it's based on social justice. And we said that is the basis for anything related to women and health. And that providers and recipients of care must be part of it. Roles and their work has to be part of it. And that this is, and all the transitions that are happening in the world need to be part of it. And we put our heads together, this from all these different countries, and we said there are 4 recommendations. Those 4 recommendations have to be at all levels. In our hospitals, in our societies, in our countries, in United Nations, at all levels. Value women, count women, compensate women, and be accountable to women. And I want to say something about each one of those. Value women, recognize women's paid and unpaid contributions as healthcare providers. This needs to be recognized. If you really want women's health, you want to decrease infant and maternal mortality rates, value women. Value their paid and unpaid. Develop, implement, and enforce gender-responsive policies to support women in their diverse roles and enable them to integrate their social, biological, and occupational contributions. Not taking away their biological contribution, but put it there. We said Health is not about absence of disease. Health is really about empowering people in general, but empowering women, developing agency in them. This goes for our students. We need to empower them and develop their agency too, to achieve the integration of their roles, to really respect all their roles, their history, so they can advocate for self and advocate for others. In that case, nursing is about empowerment and change of structures. That's what nursing care is about. It's broader than pain management. It is about changing the structure for pain management that undermines some minorities in receiving medication. You put that on anything that we do. Women's work and empowerment are part of the complex dynamic relationships of the formal and informal workforce within the larger social, economic, and political context. Work is influenced by health, and it influences health in return. We want more productivity from women, make them healthy. We want to make them healthy, respect their productivity. So we have to define women's work. Women's work is not working or not working, or working in a hospital, not working in a hospital. We really need to deconstruct work for women and research the different aspects. Now, what does that mean? It means that if we want to study women's work, we have to study the time they spend in planning, getting to and from work, and the transportation, the energy and the activity that they spend in it. The space that they work in that stresses them or doesn't stress them. How many times do we enter schools of nursing in some countries where it is you enter other schools and you say how lavish it is, and you enter a school of nursing and you find that the space that's allocated for nursing shows that that is not really a valued profession in those countries. I think that's really important to think out geographically and space. The meaning, the emotional involvement, the worry, the grief, the relationships that they have, the direct and the indirect results of contribution to production or service or goods, the personal and environmental resources. You want to study women's health? Women and health, study the resources, study the environment, study the values related to that profession, related to that work that they are doing. Study the personal and societal affirmation. Developing enabling environments for nurses and policies addressing the undervaluation of female healthcare providers are crucial to the health and well-being of populations. It's crucial to the health and well-being of all populations. Dr. Lake yesterday did a beautiful job, and in Spanish. I'm so jealous. She did it all in Spanish. Showed how health environment for nurses influence them personally, but it also influences the work they do, and it influences the outcomes. Enabling environment and safe environment is what nursing should be studying too. Respecting of contributions, that's for nurses, but that's what we need to study. Flexible work schedules, all these are part of enabling and safe environment for women and for nurses. Opportunities for progress, leadership opportunities, environments that are devoid of incivility, of aggressions, of abuse. We want to study the effect on women's health. We have to see what the providers are, what kind of environment they have. And I don't know if Dr. Nancy Gonzalez Cruz is in this audience here from, and her team of researchers from Tampico School of Nursing, because they have, and I can't pronounce the university name, Timalapias. I have been trying to study that word. I have been there, and I'm very impressed with what they are doing. They have a great paper on the quality of work life in primary care for nurses, because we have studied it in hospitals, but we have not studied it in primary care. And they found out that many of the things that are really stressful for nurses are lack of inclusion in workplace, the sense of lack of well-being in their work environment, the lack of support, and the lack of safety. Therefore, the outcomes in patient care are affected by that. So the first one is value women, value their work, and second, count women. Count them. You can imagine in some of our Lancet reports where we went to different countries to find out the different levels of nurses, who the nurses are, who are the caregivers, and we couldn't find any data. If you can't find data, if you can't find data about people, you're not honoring the people, and you're not able to really provide better education for them and better statistics are very important. Census are very important. It was only 25 years ago when we began finding out in the United States that we're not supporting women scientists. Only 25 years ago, women scientists of every kind. And we also found out 25 years ago that we're not studying women. We really don't know much about their cardiovascular system and whether they should take aspirin or not. It was only 25 years ago. We're celebrating that right now. And more recently, we found out something else that's going on. When mice are studied, it's usually the male mice. And when cells are studied, they're usually the male cells. And yet, the decisions about medications, about interventions, are made on those cells that are male cells and male mice. So NIH put $50 million aside and said, anybody now who's going to compare and contrast male cells and female cells in a study of medications, I think they're going to get some of this. So count women, count them in what we are doing, but publish about them too. And it's only by counting fetuses and babies that were aborted that we have learned that there is selective abortion of girls and that the ratio of boys and girls is changing in some countries like China, India, Pakistan, among many others, because when they found out technology is great, now we found out that we're going to have a boy or a girl, we have a girl, let's abort the girl because we really don't want girls, so let's get. So that's counting, that is making us realize some of the changes. But also by studying minorities, you have lots of minorities in your country, and we have lots of minorities. And it's only recently that we started having special research related to diversity by studying healthcare of women of minorities. We have the Nigerian immigrants, and we have, of course, the Hispanic is large, but there are others. All right, so what else? Compensate women, we said in our report. Women's economic contributions to health are healthy women are more productive, we know that. Their health is improved, their nutrition is improved, they increase their earnings, but actually what's happening is that women invest, and when women are well compensated, that's another thing to remember, when women are well compensated, 90% of their earning goes to their family and their children and raising their children, as compared to 30% to 40% of women breadwinners. So compensate women. Recognition, valuation, and compensation of women's roles in healthcare are necessary to achieve gender equality and maximize women's contributions to families and communities. But we have to be accountable too. It's not enough to make all those recommendations and not really track it and find out what's going on. Tracking it in my university is by finding out male professors and female professors how much they are making, and finding out how many of the female professors stay at the lower echelons and how many of the male professors go up. Only by counting that. I have been in teaching now 50 years in the United States. We started doing that at the University of California, San Francisco, way back to find out that there were total unequal pay and unequal compensation. But it's by accountability. Accountability, a commission that was established by United Nations have showed that which require tracking and require of policies and of implementation and regular reporting has helped 17 countries show increased gender equity and for compensation and valuation. Afghanistan, Cambodia, and so 17 countries, because we are forced to be accountable. Nurses could use the positive aspect of their public image as caregiver to further the visibility and work done by all women. We claim ourselves as part of that. And we must use our voice. for that. Now, are we making progress, people? How do we measure progress? Well, there are different theories to measuring progress. You thought you'd get away without my saying something about theory here. Theory, there is revolution theory. Kuhn said, sudden changes, that shows there is progress. Well, there are no sudden changes that are happening. There are few changes that happen. There is evolution theory that says unfolding from lower to higher, from simpler to more complex. So that might show us a little bit of progress that we are happening. But I really believe we need to look at integration theory. We need to, which bits of both evolution and bits of evolution. And there are some good signs of that. United Nations, our President, Obama, made the pledge coming from the White House that all companies have to have equal pay pledge. Universities and companies, and these are the companies that took the pledge. Massachusetts, Boston, made a law that you cannot ask. Are you there? Did you find yourself there? Massachusetts made a law that you cannot ask a woman employee about how much money they were making before, because they found out when you ask that question, you just get a little bit of increase and you give it to them, because women are discriminated against in all jobs, so they never really increase. So there is a law. So that's progress. Other signs of progress? See, I'm going beyond mortality and morbidity to really find out if we are making progress. Well, the pink taxi in Mexico is progress, because it's something that's important for women. In Egypt, there is the harass map. With social initiative that was developed. There is a map of harassment, and you can report harassment in the streets right away. A very exciting thing happened. This woman entrepreneur bought banana fiber that women had the bananas, and the fiber had no use in Rwanda. And a woman entrepreneur actually bought that and made menstruation pad for girls. Now you think menstruation pad, why is that progress? It's because girls didn't go to school because they had no menstruation pads. And so when she developed that from the fibers of banana fibers, they put it in every school bathroom. Girls started going to school because they are not embarrassed anymore. This is progress because these are women's issues that were not considered before, and now entrepreneurs are thinking about them. There are women-only trains in India. There is Athena jewelry, an entrepreneur. You wear it and you push the button in case you're feeling that you are not in a safe situation. And of course, there is the Greenpeace. India launched its campaign to make streets of Delhi safe by actually putting lights in it. Women and health, the future of it, we have to have an international perspective. And we have to combine it with our interest in nursing and our interest in the improvement of nursing. And I'm so proud of our university because we have the very first center for global women's health. It's the mission of that center is for global women's health is to maximize health and empower women and girls around the globe. And we have some amazing professors in it. So for the future, for those of you who are thinking about studying, if we use the framework of women and health that incorporates providers and recipients of health care, what are some needed areas of investigation? Caregiving and its healthcare needs and consequences. Integrative models of care that impact women out in the community. Violence and women's health, and how it's affecting women's health. A burden of disease on women, burden of disease for them, family burden too. The impact of public and social policy on the health of women. Strategies that women can empower women and care providers. New interdisciplinary models. International comparisons are really important. New interdisciplinary models for research. Biomarker genetic determinants of health for women. the relationship between brain functions and health and wellness behavior. To ensure sustainable growth, sustainable progress in health and safety, I think we really should focus on issues that matter for women, from women's perspective. Innovations, I mean, those innovations about the taxi and the safety gadgets, these are innovations that are protective for women. Protective policy, dialogues and actions for unwanted pregnancies. There's very little of that going on in the world. A global agency for women. So progress in women's and health is to pay attention to women as providers and women as recipients of health care. To pay attention to work equity. We all should be a voice for women and health. And whatever role they are playing, in whatever role we are playing, we can do that, whether we are teachers, researchers, clinicians. And we should make sure we are empowering women to work up to their capacity, all women that we deal with, and live a quality life, because when they live a quality life and live up to their full capacity in an equitable environment, they're going to produce more. That is part of our social mission as nurses. That is not an imposed upon us. That's our moral obligation. That's a moral imperative. And I raise all my hats to all of you for all the work you are doing, because you are doing some amazing, fantastic work in this conference. And I'm so impressed with the progress that happened in this colloquium. And I feel truly honored to have been part of this colloquium. And I want to acknowledge my partner in putting this PowerPoint together, my assistant, Kim Freeman, who is a true partner. And I thank you very much for all your attention.
Muchas gracias. Muchas gracias a la doctora Fab Meleis. Indudablemente que ustedes habrán sentido esa sensación de tenerla no solo como una teórica, sino con la sensibilidad que da, ¿sí?, el conocimiento. Y muchas gracias a Fab. Thank you. Además, quiero que vean que trae a Hillary Clinton no solo en su corazón y en las diapositivas, sino también en sus aretes. Entonces, Hillary Clinton enjoy
My earrings, all right, yes. You want to see my earrings, everybody?
Seguimos con el siguiente, por favor, la doctora Meleis va a estar por aquí varios días con nosotros y vamos a dar paso al siguiente panel, por favor.
I'll sit down, collect my stuff.
Sí, déjame ver. I need interview for you,
Okay.
for the word.
Oh, sure.
Yes. Sí, terminando.
Thank you very much. I know, but you like it. Thank you very much.
With the mouse?
Yes, with the mouse.
Okay.
Yes. Thank you.
Yes.
Thank you.
Yes. Excuse me. I want to show you. Voy a presentar Buenas tardes. Continuamos con nuestro programa. Queremos hacer de su conocimiento, se han repartido físicamente, por ahí lo van a recibir, de manera impresa los boletines de prensa que corresponden a los días previos y un flyer en donde se indica exactamente el sitio, ya lo habíamos comentado desde el portal de la Escuela Nacional de Enfermería y Obstetricia, www.eneo.unam.mx. En el cartel que aparece en la notificación del coloquio panamericano, en la pestaña que dice más información, ya pueden bajar boletines de prensa, videos, las conferencias, entrevistas con los conferenciantes magistrales y diversas fotografías, porque sabemos que lo han estado solicitando. Así que ya está a su disposición. Les pedimos, si son tan amables, de tomar asiento para dar continuidad al siguiente simposio y estar en tiempo y forma cumpliendo el programa. Asimismo, hacemos de su conocimiento que en breve, en los espacios de intermedio entre las distintas actividades académicas, al principio y al final de las sesiones de cada día, estarán apareciendo en pantalla fotografías y videos alusivos a las actividades realizadas para este día. Damos paso así, les pedimos, si son tan amables, de ocupar sus lugares.
Bueno.
Al simposio número 3, intitulado Enfermería de Práctica Avanzada, Estrategia hacia la Salud Universal. En esta ocasión coordinará la mesa la doctora María Dolores Zarza Arizmendi, de quien voy a dar simplemente algunos datos de su currículum. La doctora María Dolores Zarza Arizmendi es directora de la Escuela Nacional de Enfermería y Obstetricia de la Universidad Nacional Autónoma de México, enfermera técnica por la Facultad de Enfermería de la Universidad Autónoma del Estado de México y licenciada en Enfermería y Obstetricia por la ENEO-UNAM. Es maestra en Comunicación y Tecnología Educativa por el Instituto Latinoamericano de la Comunicación Educativa. Es profesora asociada, ha impartido clases desde hace 28 años. A lo largo de su trayectoria, resalta su experiencia como enfermera en diversas instituciones de salud en el área de pediatría y otras, siendo y teniendo en su haber el cargo del jefa de servicio de pediatría, entre otros. Ha ocupado diversas coordinaciones dentro de la Escuela Nacional de Enfermería y Obstetricia como coordinadora de los cursos posttécnicos en Administración y Servicios de Enfermería. Ha sido coordinadora académica de la carrera de Enfermería, de la licenciatura en Enfermería y Obstetricia y secretaria general. Ha publicado más de 15 artículos científicos en revistas indexadas y participa como representante institucional en diferentes comités académicos, como miembro de la Junta de Gobierno de la CONAMED, entre otras, y con un doctorado por la Universidad de Trujillo, Perú. Queda con ustedes para coordinar esta mesa la doctora María Dolores Zarza Arizmendi.
Sí, muchas gracias. Gracias, realmente es un privilegio compartir esta mesa con enfermeras de tanta trayectoria, pero sobre todo estudiosas de la práctica avanzada. Ya en sus presentaciones seguramente nos percataremos de todo este bagaje de conocimientos y la experiencia que tienen al respecto de la temática. Entonces, bueno, muchas gracias por acompañarme en esta mesa, muchas gracias. Y bueno, pues leí antes de venir a esta sesión un artículo que escribe la doctora Silvia Cassiani junto con Lauren Kelly, en donde ellas hablan de cómo la escasez de proveedores de atención a la salud es una barrera para lograr el acceso universal a la salud. La OPS y la Organización Mundial de la Salud aprobaron en una resolución aumentar el acceso del personal sanitario capacitado en sistemas de salud basados en la atención primaria. Y ahí es donde incluyen
de manera muy importante a la enfermería avanzada para esta práctica, y es una estrategia importante el apoyar a la formación de enfermería, les decía, en esta práctica avanzada, facilitando la cooperación entre países, sobre todo en América Latina. Entonces, esa es la intención de esta mesa. Tiene un objetivo muy claro, que es conocer, ¿sí?, hacia dónde va la enfermería en práctica avanzada y qué podemos hacer los países que aún no hemos incursionado o que estamos en vías de incursionar en esta práctica avanzada, y que sobre todo se considera como la estrategia esencial para avanzar en la cobertura universal de salud. Para eso, contamos en primer lugar con la participación de la doctora Denise Bryan. Ella es profesor asociado de la Escuela de Enfermería y del Departamento de Oncología, y también es coordinadora del Centro Canadiense para la Práctica Avanzada de Enfermería. Es directora del Centro Canadiense de Investigación, y incluyen aquí el tratamiento de cáncer y de la supervivencia, la navegación y el sistema de transición entre el cáncer de servicios y la atención primaria de la salud. También el control de enfermedades crónicas, apoyo a la autogestión, el dolor y los síntomas de gestión y toma de decisiones sanitarias basada en datos. Entonces, tenemos el agrado de contar con la presencia en esta mesa de la doctora Denise. Agradecemos mucho su participación y le damos el micrófono para su presentación. Adelante, doctora.
Thank you very much for that warm introduction. I'm delighted to be here. What? Can you hear? Is that better? No? That was better. How's that? Okay. All right. Can everyone hear me at the back now? Can you? Okay. So I'll start again. Thank you very much for inviting me here today. It's a pleasure to be a part of this very exciting conference, and I'm learning a lot about nursing in Latin America. Today I'm going to share some experiences and lessons learned from a Canadian context and at the School of Nursing at McMaster University about advancing nursing roles in primary health care, and briefly describe some collaborations that have occurred between PAHO and the WHO collaborating centers to move the APN agenda forward in Latin America and the Caribbean. So just to start, a bit of a definition about, well, what do we mean by what is an advanced practice nurse? And this is the ICN definition, and it's deliberately broad to take into the account that nursing and advanced practice nursing are at different stages of development around the world. And they describe the advanced practice nurse as a registered nurse with expert knowledge base, complex decision-making skills, and clinical competencies for expanded practice. And the characteristics of these roles are shaped by the context and the country where advanced practice nurses work. There is international agreement that a master's degree is the level of education required for entry to practice. So as you can see from this map and the circle at the bottom of the map, that Canada is a very big place. So that circle at the bottom of the map is McMaster University, where I'm from. And although Canada is very large in size, it's very small in population, with just a population of 37 million. So the size of Mexico City, the population of Mexico City is about 2/3 of the size of the Canadian population, to put that in perspective. And most Canadians live in the southern portion of the country, in urban centers along the border with the United States. But about 20% of Canadians live in rural, northern, and very remote or isolated communities where there's very limited access to healthcare providers or services, and that certainly was the impetus for the introduction of advanced practice roles in Canada. Canada recognizes two types of advanced practice roles: the clinical nurse specialist and the nurse practitioner. The early development of advanced practice roles at McMaster and in Canada started with the Kurgan Report. And Dr. Dorothy Kurgan was the Dean of the School of Nursing at McMaster at the time, and her report outlined the need for expanded nurse roles in primary health care in Canada. And following that report, McMaster and other universities started programs to prepare nurses in expanded roles as early nurse practitioners for isolated communities and in family practice. And alongside this, there were many pilot projects and research studies to evaluate the effectiveness of these new roles, the most famous of which is the Burlington randomized control trial that was conducted at McMaster. But despite good evidence, in the 1980s, we had a bit of a roadblock in APN role development when most nurse practitioner programs in the countries closed. And there were a variety of reasons for that, but the major reasons were a lack of dedicated funding to hire nurse practitioners into the role, and also that nurse practitioners had been very much focused on a physician replacement model, and that made them vulnerable to cutbacks and to lack of funding in a healthcare system where there was a perception of an oversupply of physicians in urban settings. In the 90s, though, we saw a resurgence of interest in the advanced practice role, with primary health care reform becoming a policy priority in all provinces. And the Ontario government, where I am from, decided to fund a comprehensive needs assessment to justify the need to introduce nurse practitioner roles and to see if they could overcome some of the barriers to role implementation that was experienced in the 1980s. And that needs assessment was conducted by Dr. Alba DiCenzo from McMaster. And the results of that needs assessment led to the introduction of a 10-university consortium to deliver baccalaureate nurse practitioner education for primary health care in the province. In the 2000s, we saw a shift with nurse practitioner education moving from the baccalaureate to the master's level, and this was very much a push by nurses and nurse educators despite lack of government support to actually fund master's education. We also saw the development of nurse practitioner competencies to guide the development of licensing and regulation, and also curricula. And a really important event in the 2000s was the funding of a national chair in advanced practice nursing that was held by Dr. DiCenzo at McMaster. And I was fortunate enough to be a PhD student, a postdoc fellow, and a senior scientist in the chair program. And through the chair, we were able to build capacity in developing PhD-prepared faculty, conducting decision-maker-linked and policy-relevant research, and developing evidence-based tools such as the PEPA framework to guide the effective use of the roles. Excuse me. By 2010, the chair program had really had a lot of impact in Canada, so much so, excuse me, that its research was the focus of the first ever special edition on advanced practice nursing in the Canadian Journal of Nursing Leadership. But in 2011, the chair program concluded, and graduates of the chair program, like myself, who were from other universities and provinces, really felt that we were just getting the development of APN rules started and that there was more work to be done. And so we established the Canadian Centre for APN Research that includes multiple faculty, oh dear, but is hosted at McMaster. And our work at CAPNR has now expanded internationally with a real focus on models of care and skill mix as global policy priorities, and really working to look at not just the optimization of advanced practice roles, but also RN roles in primary care. In 2016, CAPNR faculty are now editors of a second special edition on advanced practice nursing, and we've had the opportunity to look back at the last 5 years and what's been achieved. And certainly there has been substantial progress in a number of areas. A key one is regulation, where we have firm regulation in all 13 provinces and territories, and almost all barriers to optimal NP scope of practice have been eliminated. But still, full integration of advanced practice roles into the healthcare system has yet to be achieved. So, what are some lessons learned from our experience over the last 40 years? Well, first is that strong nursing leadership at clinical, academic, and policy levels is essential to continually drive the introduction and effective development of these roles and to get them integrated into health systems and organizations. And it's challenging because the formal policies to support their implementation are lag behind the informal introduction of the roles. And the integration is really it's a slow and evolutionary process with some ups and downs in success. There are also existing healthcare policies that need to be overcome. And a good example in Canada was physician fee-for-service funding models that really became a barrier to the introduction of nurse practitioner roles. A second lesson is that a systematic approach to the introduction of APN roles is essential to design the right roles to address population, health, and nursing practice and health system needs. And currently in Canada, most provinces require that the PEPA framework be utilized to design and introduce new advanced practice roles. And the framework is now being used in many countries around the world, not just to introduce advanced practice roles, but other health provider roles as well. So, where are we today? Primary healthcare nurse practitioners are considered the backbone of rural, northern, and remote healthcare in Canada. They are the primary providers for at-risk and hard-to-reach populations in urban communities, and they increase access to care in underserviced communities through NP-led interprofessional teams. Sorry. That's right. Nurse practitioners now manage teams and hire physicians to be part of their care team. That was a major success. CNSs were also introduced to address needs in community-based Aboriginal primary health care. And in 2005, Health Canada introduced clinical nurse specialists in over 600 First Nation and Inuit communities. And this followed a very comprehensive needs assessment, I have to say, using the PEPA framework to address unmet health needs, improve the recruitment and retention of nurses, and improve the quality of nursing care in high-risk priority areas. A third lesson learned was that standardized, coordinated, and a collaborative approach to APN education among universities was necessary to address our resource and policy issues and address variability in practice. And certainly the consortium of universities to deliver NP education in Ontario So this was 10 universities. It allowed us to standardize NP education across those universities. It helped us to share the costs of program development, and also the fact that we had few NP faculty to teach in these programs. It helped us to develop NP faculty and expertise across the province. And finally, it wasn't a plan, but it led to developing a very cohesive lobby group to advocate for policy changes for nurse practitioner education. A fourth lesson was that integrated knowledge translation that engages policymakers and healthcare administrators throughout the research process increase their awareness, understanding, and uptake of best practices for using advanced practice roles to address priorities for healthcare improvement. And the slide shows 2 examples of briefing notes that we developed to articulate the effectiveness of advanced practice roles. And these were designed to educate healthcare administrators. And we developed them in collaboration with a group of national healthcare decision makers, and they told us what were the key messages we needed to get out and what was the best format for delivery. A fifth lesson was that pan-Canadian collaboration through the APN Chair Program and CAPNR has been effective for building and sustaining APN faculty for education and research, generating evidence to influence policies and practices, maintaining a momentum in developing APN roles and keeping their profile high, and establishing a network of nurse leaders and advocates to address policy issues and implementation challenges. A sixth and final lesson learned was that the world is a very small place, and that international collaboration and partnerships benefit advanced practice role development in countries like Canada, where APN roles are already established, and in countries where they're just new or emerging. And a good example of international collaboration is the work that's happening between PAHO and the WHO collaborating centers in the US and Canada, where we're working together to support the introduction of APN roles in Latin America. And McMaster was fortunate enough, privileged enough to host the first APN summit last year. But this work has continued in 2016, where the University of Michigan hosted a second summit looking at APN competencies. McMaster and PAHO also hosted a very well-attended webinar series on APN role development, education, and regulation. And most recently, PAHO has established a Pan-Canadian Advisory Committee to develop APN role competencies for the region. Further collaboration evolved from these meetings to look at how could we best align APN roles and what we know about their outcomes with policy priorities for achieving universal health coverage and universal access to health in Latin America. And so this is a paper that's just been accepted for publication, and it illustrates APN outcomes that have been synthesized from systematic reviews and how these roles can be used to address healthcare inefficiencies. And the paper suggests that cost savings gained through the introduction of these roles can be used to offset the costs for universal health care coverage. A final point around international collaboration is a policy brief that the CAPNR group developed for ICN. This is a policy brief for national nursing associations to provide some guidance for how to go about designing, introducing, and evaluating APN roles, and you can find this on the ICN website. So in summary, McMaster's had a long history in the development of APN education and research, and while much progress has been made and we're seeing improvement in terms of access to high quality care, continued efforts are required to produce and use better evidence to support their full integration into the healthcare system. Gracias.
Sí, agradecemos a la doctora Denise Bryan su participación en esta mesa y tengo el agrado de presentar a la doctora Jos Pulsini, que nos acompaña de la Universidad George Washington. Ella es profesora y director de Iniciativas Globales y Comunidad. Antes de llegar a esta universidad, fue miembro de la Academia Americana de Enfermería, editor asociado y senior de Política y Práctica de Enfermería, y es revisor de revistas importantes de enfermería. Se desempeñó también como director ejecutivo de la Red de Escuela de Investigación en Enfermería en Massachusetts y ha sido miembro de la Junta de Supervisión desde el 2005. Es autora de más de 40 artículos, 11 capítulos, 8 documentos de política y en 4 de ellos ha sido primer autor. También 2 ediciones de un libro de texto. Entonces, adelante, doctora, gracias por estar con nosotros.
Gracias, muchas gracias, and buenas tardes, mi amigas and amigos. That's all you're getting in Spanish. I'd like to thank you for inviting me. I'm very honored to be here to talk about the development and education of the APN role and for nurse educators. This presentation will discuss the presentation of APN nurse education and the mentoring of APN nurse educators in the U.S. with application to Latin America and the Caribbean. I will include a history of NP education and the successes that we experienced when nurse educators came together to create common goals. And it will also discuss strategies for incorporating new and existing new educators into APN education. So I will be talking a little more less about the role and more about how an organization like yours can really help to advance the APN role. And I'll use the examples from the U.S., which is what I'm most familiar with, but I think they actually apply very well. This is the definition of the advanced practice nurse in Spanish, which Dr. Bryant Lukosius just gave you, so I won't go over that again. But the educational preparation for the advanced practice nurse is at the advanced level, should be at the master's level, and should be part of a formal program that's recognized that prepares nurse practitioners or advanced practice nurses through accredited and approved programs. There should be a formal system of licensure, registration, certification, and credentialing in a country so that this can be supported in the long term. And this is, of course, really very important. The nature of practice of the APN includes, research, education, practice, and management. And there's a high degree of professional autonomy and independent practice that evolves over time. So let me say that in the beginning you won't be as independent, that there's an evolutionary process with that. They can manage ultimately their own caseload, use advanced diagnosis and health assessment skills, decision-making skills, diagnostic reasoning, and you work with recognized advanced clinical competencies. And they might be providing consultant services to other healthcare professionals as well. They plan and implement programs and are recognized as the first point of contact for clients in a primary care system. So what is primary care? And again, we're going back to oops, let's see, okay. Okay, this is the regulation, the regulatory component for So there's a whole set of regulations that are involved with advancing this role, so that this really gives you the overview of the regulations or the mechanisms for regulation for the advanced practice role, which I won't read to you, but you can use, and these all come from the ICN Advanced Practice Network. So what is primary care? Primary health care, essential health care based on practical, scientifically sound, and an acceptable method and technology that's universally acceptable to all in the community through their full participation at an affordable cost and geared towards self-reliance and self-determination. So this is first-level care, primary care, really essential care for all populations. And this is what we are mostly focusing on here. And of course, advanced practice nurses do work in secondary and tertiary levels as well, but we won't focus on that as much now. So I'll talk a little bit about the history of nurse practitioner education in the U.S., and I think it is relevant. We have a long history. Our program started 50 years ago, so we have been through a whole evolution, and I think we actually have a lot of lessons for you to learn that we can, because we made a lot of mistakes. We started with certificate programs, for example, which were not yet at the master's level, and it took us a long time, almost 20 years, to get beyond those certificate programs. So it's wonderful that you're talking about master's education to begin with for the advanced practice nurse. The first nurse practitioners in the United States, this is the nurse practitioner role now, and we do recognize 4 roles in the U.S. The NP, nurse practitioner, the CNS, the nurse midwife, and the registered nurse anesthesiologist. So there are 4 advanced practice roles in the U.S., but I'll focus on the NP. The first NPs were public health nurses. They were public health nurses working in rural areas in Colorado, and it was a time when there was a shortage of physicians, and there was a great need in the population out there, and so that it was thought that if you take public health nurses, who actually are fairly independent anyway, and give them a formal education, that they may be able to raise the level of their practice. And indeed, that was accurate, and the first were in pediatrics. Later, family nurse practitioner programs came to be about 5 years later, and you can see here how it's grown from 65 nurse practitioner programs in 1973 to well over 300 in 2000 and many more today. So these numbers have really grown astronomically. It really took off in the United States. But I want to talk about the group of educators who first got together in 1974 to talk about curriculum, and that led to the organization that we call NOMF, the National Organization of Nurse Practitioner Faculties. And that organization truly took the lead in developing curriculum, to standardizing curriculum, identifying what that curriculum should look like over time. And they developed in 1980 the first guidelines for curriculum planning for FNP programs, and those were revised every 5 years. Since then, those were revised until 1995, when we moved into competencies. So we started with kind of a more prescribed curriculum and moved to competencies, which is where we should be. We should be looking at outcomes, competencies with these programs. So another little lesson. The federal government did support these programs, and that was very important. The other thing that NOMF did was that they brought together all of the 24 different nursing organizations and created the National Task Force criteria for evaluation of nurse practitioner programs. So they brought in not only the educators, but the certifiers, the regulators, the accreditors, the different organizations together in one room, and they agreed on these criteria. That was a really hard thing to do, to get these people to all agree. So that was really very important. And now we have almost 200,000 nurse practitioners in the United States, so we've grown tremendously. So like in Latin America and the Caribbean, the earliest graduate programs in nursing focused on nursing theory and on preparing teachers and administrators as appropriate. And doctoral education was well established in the United States in the 70s and 80s, very much focusing on theory and research as they should. The clinical nurse specialist role preceded the NP role in the United States, and they were initially mostly in acute care. They moved more into the community, and also there were psychiatric clinical nurse specialists who were fairly independent, one of the early independent roles. As we moved into this primary care and direct care focus for NPs, many educators were quite skeptical of this role. They thought we were many doctors. We actually felt those of us who did this in the early days, felt very much on the outside. We were on the outside looking in. We were a small group, but very organized in developing this curriculum. And we didn't see it that way. A nurse practitioner really provides, when they're able to provide full access to care for a patient, that provides access to nursing care for that patient. And what that has led to is the fact that our nurses in the United States are the #1 most highly thought of profession in the country. And also APN roles really caught on with our young people. They wanted to do this. They wanted to have this advanced role. So the numbers grew in the programs, and the status of nursing rose I really believe, because of the APN role, because young people really saw this as something they wanted to do. So we had to, faculty had to practice. That was part of what we required, and that was a real challenge. In order to be certified, they had to practice. So they really had to maintain that practice while they were teaching, and NOMF advocated for this. One very important program that I'd like to really highlight today was between 1976 and 1982, the Robert Wood Johnson Foundation offered the Nurse Faculty Fellowship. It was a fellowship for faculty who were brought to, I believe it was the University of Rochester in the States, and they were actually given a couple of years to become nurse practitioners, to be taught. And the goal was to create a corps of leaders in nurse practitioner education who could help establish master's degree programs in schools of nursing. And this, I believe, really led to this proliferation of programs. By 1993, we reached a tipping point. Almost all graduate programs in the United States had nurse practitioner programs, and I am convinced that this faculty fellowship was very important in that, because we were part of the norm. We were no more on the outside looking in. We were part of nursing education, and we just grew together after that. So we have to bring faculty along if we're going to do this. Faculty cannot feel like they're on the outside. And this was a really good program. And one person who I would point out who was in this program was Polly Bednash, who was the director of the American Association of Colleges of Nursing for years. So she was actually one of the people in this program. So again, NOMF, talking about NOMF, really I talked about the National Task Force criteria, which set standards. We had the American Association of Colleges of Nursing and NOMF developed the essentials for master's education, and then the consensus model, which I'll talk about, for nursing education. So by the year 2000, we saw that we had to really standardize the curriculum. We had to standardize what these roles look like. We have 50 states, a lot of people, hard to get all those people working together, but we did it. We got them all together. And we set those standards, and now we have a fairly standardized education and role. So this is the APRN regulatory model. that I talked about, and here it is in Spanish. And so again, the 4 roles on the bottom, and then we said that in order to be a nurse practitioner or advanced practice nurse, you had to choose one of these 6 areas. We also had a lot of specialization, people calling themselves cardiac nurse practitioners or oncology nurse practitioners. We said, no, you first must be a generalist before you can be a specialist. So this was a very big change. It really affected education, and we, again, all came together to agree on this. And this is the LACE model, which kind of talks about what the curriculum should look like. Here it is in Spanish, you know, with the graduate core, and then the advanced practice scientific foundation of pathophysiology, pharmacology, and health assessment, and then role. We always focused on, all through these years, we've talked about role change, how to make change in the role, and then of course the organizational and policy issues, and of course competencies in clinical practice, not to leave those out. So we have 3 levels now. We have the master's degree, we have the doctorate of philosophy, the PhD, and the doctorate of nursing practice. And I would love to talk with you more about this, but we're not going to. Dr. Melise raised the question, we could debate this, and I think it's very important, but we do have the DNP is actually growing very rapidly in the United States, and much more rapidly than PhD programs. It is a entry-level clinical doctorate, and puts nurses on par with PharmDs, pharmacy doctorates, OTDs, PTDs, and medical doctors. By the way, a medical doctor is a clinical doctorate. It's not a research doctorate. So it puts us all on par with this clinical doctorate. So they're now equal in the clinical area. So that's all I'll say. So then we also worked since 2000 on these documents, which I won't read, but these documents that led to the work on the DNP. So we had Essentials of Doctoral Education, the Nurse Practitioner Core Competencies that were revised over time, and work on the Practice Doctorate entry-level competencies. Again, NONF, the National Organization of Nurse Practitioner Faculties, was very central to all of this, an organization like yours, which made a huge difference over these years. So I'd like to emphasize that that is something you can do. Now, I was going to talk about competencies and all the different competencies, but I think I might stop here because I do know that we're short, and I don't want to go beyond my time, which I already have done. So we have, if you go to the NONF website, you'll see all of the competencies that we have developed. You can download them and look at them, but they were competencies that were developed across the different specialties over time and revised almost continuously so that we can be right up to date. And these are the 9 NP core competencies in the U.S. Thank you. Muchas gracias.
Muchas gracias, doctora Joyce. Agradecemos su participación en esta mesa y presentaré a nuestra siguiente ponente, a la doctora Adelaide Markaki. Ella es la primera enfermera de práctica avanzada en Grecia, que se certificó en salud pública y en comunidad. Posee el doctorado en la Facultad de Medicina de la Universidad de Creta en Grecia y una maestría en Ciencias de Enfermería y también máster en Antropología Médica en Estados Unidos. Su experiencia profesional se extiende a más de 30 años, donde ha desarrollado roles como en la clínica, la investigación, la administración y en la consultoría. En el 2010 fue nombrada instructora del Departamento de Medicina Social de la Universidad de Creta y fue titular hasta el 2014. Las principales líneas de investigación de la doctora Markaki son los sistemas de salud y los resultados en el campo de la atención primaria de la salud, que incluye un enfoque interdisciplinario para la atención crónica. También del cuidado compasivo, desarrollo de capacidades de recursos humanos y la enseñanza entre profesionales. Entonces agradecemos la participación de la doctora. Adelante, doctora.
Gracias.
Good morning. I am delighted to be here with you in this amazing conference. You will have to excuse me not speaking in Spanish. This is my first trip to Latin America. I would like to thank the organizing committee for inviting me to share my thoughts and my experiences. And trying to do that, I would like to take you to a transatlantic trip, a mental one, perhaps. Let's cross the ocean. So if you want to fasten your seatbelts and go to Europe and look at advanced practice nursing and universal health, whether this is a utopia or a necessity for settings that have limited resources. So let's start by saying what is known in terms of the systemic problems. There is a lot of literature, there is a lot of evidence that the healthcare workforce in the developing and the developed countries are facing issues such as imbalances in the professional labor market, both qualitative and quantitative imbalances. There is very narrow technical focus that does not look at the broader contextual understanding and picture. And the encounters of nursing care tend to be episodic, one-time encounters, rather than continuous care. Teamwork is not very strong. There is a lot of orientation towards hospital care rather than primary care. And our leadership in improving health system performance is also lacking. These are the systemic problems. But besides these, there have been some opportunistic problems that have been identified by WHO. And these stem from the migration issue, which is a key issue that PAHO and WHO nursing officers have to deal with. We know that nurses, and not only nurses, but we're talking about nurses here, migrate from rural to urban, from poor to wealthy counties and countries, and that creates a scarcity and an imbalance in the nursing workforce. The result of that is that the availability and the quality of the healthcare services in the rural areas is impacted, obviously, and the end result is that the health status of the rural populations is not the optimum. So why should we invest in human resources for health? Well, there are three things that are very good. We get improved health outcomes, global health security, and economic growth. And yes, this latter one, the economic growth, is something that we need to convey to the policymakers, the ones who make decisions. Investments, though, in human resources must be tailored to the national setting and to the fiscal realities of the national setting. So in other words, one size does not fit all. We have to see what each country's unique requirements are, what the economic situation and the fiscal realities are, and then target those. The positive impact can go far beyond the health sector. So, for example, better evidence and use of new tools and approaches can maximize the returns on the investments. But a word of caution, high-level political commitment of the government is required in order for us to have those investment returns. Otherwise, we cannot be effective. All right, so let's look then at what is happening across the Atlantic, and I'm taking you to Greece. If you have never visited Greece, this is your chance. It's a member of the European Union. It's the southeastern border. You have probably heard about Greece in the news for the past 6 years, that it's going through economic austerity and recession, something that might not be very unfamiliar to some of you here and some of the Latin American countries. There have been repeated reforms of the national health system and the primary health care system. We have severe shortage of primary health care nursing staff in our rural and urban areas. There are no advanced practice nurses. There's no legislation for advanced practice nursing. And the health profile of the population and the health indicators, morbidity, mortality, have been severely affected by the prolonged crisis. So what is the scope of primary healthcare nursing practice in Greece? We heard a little bit before about primary healthcare practice in Canada. Well, it's restricted, it's task-oriented. There is resistance to organizational change and innovation, and that's related to how much restricted a nurse views her role. The educational preparation that the nurses have plays less of a role, has less of an effect in the practice variations and the professional needs compared to other countries. And the nurses lack specialized education and training so that they can function autonomously in the community. So there is lack of autonomy. Mobility and professional growth opportunities are almost non-existent, and about 1/3 of the staff reports poor job satisfaction, and about 19% think of leaving the profession or leaving that particular area of practice. So how can we build the case for advanced practice nursing in Greece? Well, we need to look at 5 areas that were identified previously by the previous speakers very nicely. So we kind of worked along the same lines. We looked at chronic disease management, where advanced practice nurses can play a huge role in early detection, in evidence-based interventions, and best practice guidelines. We looked at continuity of care so that we can have less fragmentation, integrated and coordinated care so we can have less readmissions, less hospitalizations, collaborative care, and of course, cost-effective services. So what we did at the University of Crete, and that's the School of Medicine, the Clinic of Social and Family Medicine, we tried to work through either PhD studies or postdoctoral studies and look into the poor management of invisible diseases and conditions such as dementia, depression, anxiety, urinary incontinence, or the lack of clinical skills in patient-centered care, such as motivational interviewing or coaching lifestyle changes. And although not all of the studies were done by nurses, they were done by general practitioners in many cases, we tried to tailor and have like a byproduct of the findings of the study, what could be the contribution of an advanced practice nurse in these kind of situations. So here you can see a couple of examples. One of them was the development, actually the translation, the cultural adaptation and validation of the EPDS scale. It's the Edinburgh Postnatal Depression Scale that measures and screens for early postpartum depression. That was done part of a PhD thesis by a certified nurse midwife. Or we looked at urinary incontinence and how that affects women's quality of life. That was part of a PhD study of an advanced practice nurse. And what are the implications for primary healthcare nurses? So we worked diligently trying to establish then a health policy agenda for Greece. And we did that through many different ways. One of them you see here, a systematic review of the needs for obtaining integrated primary health care in Greece. What are the missing ingredients for that? And based on that, we also looked into what is needed for capacity building within primary health care nursing at the European level. And later, in 2013, a consortium of researchers from many different European countries came with this report that looked into ways to strengthen primary care in Europe. And as you can see, primary care workforce development is one of the key ingredients. So based on that report, we can now look further with what are the possibilities for developing and regulating advanced practice nursing in Europe, and of course taking into consideration the differences between northern and southern countries. We're crossing the Atlantic one more time, going back to North America, and this time we're going to look at another paradigm, the state of Alabama in the USA, also in the South. Maybe a coincidence, I don't know. And let's look at some of the statistics and the state of health. It's largely a rural state. All counties have medically underserved populations. The health indicator rankings, as you can see, are very poor. It ranks 48th in overall health status. Infant mortality is very bad, 48th. Obesity, health literacy, cancer deaths, all of them are very poor health indicators. And what is interesting is this diagram that you see at the bottom, this map actually, which shows the counties in 1980 compared to the counties in 2013. In pink are the counties that had obstetrical and prenatal care services, and you can see how many there were back in 1980, and see what happened in 2013. They disappeared. This is a paradox. I mean, you would expect the opposite thing to be happening, but obstetrical care disappeared. So no wonder if infant mortality is, where it is right now. So all this gives us a picture and gives us an opportunity for advanced practice nursing. We know that to have better outcomes for chronic conditions, we have to take into consideration the social determinants of health. I won't go into that. But based on this, we can say that nurse practitioners are very much needed to act as frontline care providers in those underserved areas, to act as advocates for patients and clients, to educate and to lead. Barriers to practice, I think the previous speakers referred to them. I won't go into this for sake of time, but resistance and lack of knowledge are the major ones. So one way that advanced practice nursing could make a big impact would be through the transitional care models and closing the gaps. And in yesterday's presentation by the keynote speaker, there was Dr. Villarreal mentioned the transitional care model and how the advanced practice nurse is at the core of this model. So we know that it can be very successful. The patients who are being served are typically high risk, high cost, high volume. And of course, advanced practice nurses need to partner with hospitals because they can negotiate then and demonstrate cost savings. And I would like now to share with you, based on all this, a couple of examples and experiences from the University of Alabama at Birmingham that showcase and demonstrate that. One is the care delivery models for chronic illness that have been put into place, where we have faculty from the School of Nursing who are collaborating with nursing staff, nursing administration at the hospital, and they're providing services, one through the PATH clinic that is providing interprofessional diabetes care to patients who don't have access to services in the city, and the other is the heart failure clinic that is an academic practice partnership that provides nursing care, nursing follow-up to patients with heart failure, and try to avoid the readmissions and the rehospitalizations, so reducing the costs for the hospital. Another example is cancer care. Now here you can see an instance of collaboration between the PhD and the DNP program, and I know that there was a lot of discussion about it before. So in this case, faculty from both programs, PhD and DNP, collaborate, and they provide palliative care partnerships, cancer survivorship, navigation for cancer patients, which is so important, how to navigate the health system, and personalized palliative care. The last example I want to share with you is the Graduate Nursing Education Primary Care Scholars Program that we have put into effect. This is a way to educate more advanced practice nurses that will go and work in the underserved areas. So these will be nurses that will be prepared at the master's level as APNs, and upon finishing, they will have secured a job at an underserved area in Alabama. So in essence, it builds networks that will connect Alabama's existing care providers with one another and with UAB. This pipeline of nurses can come into any of these primary care NP programs that you see here, so nurse practitioner family, pediatric, primary or acute pediatric, adult geriatrics, or adult geriatrics women's health. They provide scholarship for the master's students to complete the program, and also mentorship, and at the end of it, they help them secure a position. So what does the future hold? I think I will skip that because the previous speakers referred to that, but I will just say that the evidence we have from other countries with limited resources is consistent with what we have been finding, and it shows that you have to have strong legislative support, a solid educational framework. These are essential critical requirements to successfully develop the APN role in universal health. Lessons learned? Well, demonstrate outcomes of care. Cost effectiveness is very important. Partner, partner, partner with consumers, stakeholders, anyone who can be important in the decision making. Step up to policy leaders at all levels and come up with innovative solutions. Take into consideration the social determinants of health, your vulnerable populations, telehealth, distance learning. Use all these means to come up with innovative solutions. And with that, I would like to thank you with a couple of pictures from the two different campuses that are now part of my life. The UAB campus in Alabama and the campus at the University of Crete, which I left behind. Thank you.
Sí, muchas gracias a la doctora Marcarqui por su excelente presentación. Sí. Nuestra última ponente de esta mesa, tengo el gusto de presentar a la maestra Paz Eugenia Soto Fuentes, de la Pontificia Universidad Católica de Chile. Ella es presidenta de la Asociación Chilena de Educación en Enfermería, profesora adjunto del Departamento de Salud del Niño y del Adolescente de la Escuela de Enfermería Pontificia de la Universidad Católica de Chile, directora de posgrado, también como centro colaborador de la Organización Mundial de la Salud, OPS, enfermería pediátrica, tiene amplia experiencia en gestión y liderazgo en enfermería, así como en la formación de enfermeras universitarias. Doctora Paz, si nos hace favor de hacer su presentación.
Hola, buenas tardes. Espero que les quede energía. Les agradezco mucho que estén aquí. Antes de comenzar mi presentación, quiero agradecer a las organizadoras de este magno evento por invitarme y por darme este espacio de poder contarles lo que estamos haciendo en Chile, qué pasos estamos dando en Chile para poder desarrollar la práctica avanzada en atención primaria. El esquema de la presentación, tiene 4 puntos. Primero quiero describirles brevemente lo que es la Asociación Chilena de Educación en Enfermería, que en estos momentos presido, el estado actual de la formación de las enfermeras en Chile y para poder hablar de la experiencia que llevamos hasta el momento para desarrollar este proyecto de enfermera de práctica avanzada para atención primaria en nuestro país. Y finalmente, unas reflexiones finales que por aquí en las presentadoras anteriores he visto reflejadas, y les juro que no hemos conversado de nuestras presentaciones, pero tenemos bastantes coincidencias. Primero contarles que nuestra asociación es de derecho privado, tiene un carácter científico y es sin fines de lucro. Tiene una trayectoria de 53 años en nuestro país y nuestra misión es velar por la calidad de la formación de las enfermeras y enfermeros en Chile. Funda su quehacer en principios éticos, en el fortalecimiento del trabajo colaborativo entre sus miembros, y eso lo quiero destacar porque esa es una fortaleza para este proyecto. El hecho de que existe esta asociación y el hecho de que impulsemos el trabajo colaborativo. Contamos con 22 unidades académicas de enfermería socias, son socios institucionales y tienen que ser unidades académicas que estén acreditadas por el sistema de acreditación de nuestro país. Y los socios individuales son todos los académicos que voluntariamente pertenecen a esas unidades y quieren ingresar a nuestra asociación. Aquí hay un mapa que muestra los programas de enfermería de nuestros miembros institucionales que están a lo largo de todo Chile, y si ustedes se fijan por ahí al medio, que en la región metropolitana es donde se concentra la mayor cantidad de programas, al igual que en la zona del Biobío, por el sur de Chile. También quería hablarles de algunos de nuestros proyectos en desarrollo, porque también considero que estos proyectos hacen sinergia con el desarrollo de la enfermería de práctica avanzada en Chile. Considero que es importante mencionárselo. Y antes de ello también decirles que estos proyectos no los trabajamos solos, los trabajamos en forma colaborativa con otras organizaciones de enfermería. Y ahí abajito yo les puse HN, pero al lado hay un símbolo que refleja la Federación Nacional de Asociaciones de Enfermeras y Enfermeros de Chile. Son enfermeras y enfermeros que trabajan a lo largo de todo el país en hospitales. Y al siguiente lado está el símbolo del Colegio de Enfermeras de Chile. Y por último, la Federación Nacional de Estudiantes de Enfermería de Chile. Los 4 representamos a todas las enfermeras y enfermeros de mi país y estamos trabajando juntos con distintos roles en estos proyectos que les voy a mencionar. El primer proyecto en el cual las chilenas lo ha liderado es el Examen Nacional de Enfermería ENEF, que es un instrumento de evaluación de los estudiantes de 5º año. Es voluntario, es confidencial y tiene por objetivo el contribuir a la mejora de los programas de formación de las escuelas miembros y no miembros de HN. Todas las escuelas del país pueden solicitar integrarse y que sus estudiantes rindan el examen. Nosotros trabajamos, este es un examen que lleva 9 años de aplicación, ha demostrado ser seguro y confiable porque trabajamos con una institución de la Universidad de Chile que es experta en el desarrollo de pruebas nacionales. De hecho, es la que desarrolla e implementa la prueba de selección universitaria en mi país, que es el DEMRE. Yo creo que eso ha sido muy fuerte y ha permitido la seguridad y la confiabilidad que tiene nuestro examen. Luego, el 17 de noviembre, hay 27 escuelas de enfermería de nuestro país que van a dar el examen, que sus estudiantes van a dar el examen. Son más de 3.500 estudiantes que lo dan en noviembre. El segundo proyecto, acabamos de ingresar al Congreso de Chile una nueva propuesta de ley para restablecer la situación de la carrera de enfermería entre aquellas que obligatoriamente requieren haber obtenido previamente el grado académico de licenciado a la obtención del título universitario. ¿Por qué es esto? Porque en Chile hay una ley que especifica qué carreras tienen por obligatoriedad que tener este grado académico. Esto hace que las carreras estén siendo impartidas por la universidad. En mi país, las universidades son las únicas que pueden entregar grados académicos. Y nosotros todas las carreras de enfermería en mi país están siendo dictadas por universidades. Pero legalmente, hasta ahora, si no logramos pasar esta propuesta de ley, podría algún instituto profesional, algún centro de formación técnica dar la carrera de enfermería, sin otorgar el grado de licenciado. Entonces, nosotros necesitamos tener este respaldo, no solo para el proyecto del cual estamos hablando, sino que para todo lo que hacemos. Es como poner en rigor, poner en propiedad lo que en la realidad se hace en mi país, que la enfermería tiene grado de licenciado y se dicta en las universidades. Además, estamos participando en una propuesta de ley para la acreditación de especialidades de carreras de la salud no médicas. Estas carreras de la salud no médica no tienen una ley que respalde las acreditaciones y nuestra carrera, por ejemplo, no tiene tampoco el reconocimiento de sus especialidades. En este momento, como aparece ahí, nosotros tenemos 23 especialidades de enfermería, ninguna de ellas acreditada ni reconocida con un respaldo legal, normativo. Dictamos 10 magísteres y de esos 10 magísteres solo 3 están acreditados. Existen 2 doctorados y solo 1 está acreditado en estos momentos. Entonces, esto también hace sinergia para el desarrollo del proyecto de atención de enfermería de práctica avanzada y de otros proyectos que queramos impulsar más adelante. También estamos apoyando la propuesta de ley de prescripción de medicamentos. Esta es una ley muy importante que está en el Congreso, pero que no ha sido movida, está descansando, como quien dice, y esta fue presentada por el Colegio de Enfermeras, pero todo el resto de las organizaciones que les nombré respaldamos esta propuesta de ley, impulsamos y apoyamos al colegio para que la restituya. Gracias a Dios con la propuesta de ley de la acreditación es indispensable también que esta otra propuesta vaya incluida. Así que esos proyectos son muy sinérgicos para lo que estamos hablando hoy en día. También no puedo dejar de mencionar que otro de nuestros proyectos es la difusión del conocimiento, es difundir la investigación, qué es lo que se está haciendo en la formación, y así es que tenemos un evento científico que se hace año por medio, que es el Congreso de HIEN, y que este año le ha correspondido a mi universidad, la Escuela de Enfermería de la Pontificia Universidad Católica, donde yo trabajo, le ha correspondido organizar este evento en conjunto con HIEN. Son las 12ª jornadas de investigación y segunda jornada de educación en enfermería, y el tema central es formación y profesionalismo en enfermería. Estamos muy contentas, tenemos invitados extranjeros bastante conocidos y también invitadas nacionales que van a ir a contar sus experiencias de investigación y de formación en este congreso. Pasando ahora a lo que es formación, una breve panorámica. Ahí tienen ustedes un gráfico que muestra la proporción de universidades que dicta la carrera de enfermería. El 75% de las universidades que existen en mi país, 45 de 60, dicta la carrera de enfermería. Y estas 45 carreras están a lo largo de todo el país. Tenemos distintas sedes donde se dicta la carrera y existen, por tanto, 114 programas de enfermería. Si vemos, más o menos el 50% de esas carreras pertenece a HIEN. Aquí está también otra información importante, ¿no es cierto?, que es los programas de enfermería que por años de acreditación que están difundidos en la Comisión Nacional de Acreditación. Hasta recién le estuve revisando y actualizándolo. Ven ustedes ahí que existe una gran diversidad en los años de acreditación. Tenemos carreras que van desde los 2 años hasta los 7 años, que es lo máximo que se puede obtener. Hay 28 carreras a la fecha que están acreditadas Y uno diría, bueno, 28 de 45 van bien. No, pero no podemos conformarnos, no vamos bien. Solo el 62,2% de las carreras están acreditadas y nosotros tenemos que tender a tener el 100% de las carreras acreditadas. La mediana es de 5 años, tampoco tenemos que quedarnos descansando en eso porque solamente pueden ser hasta 7 años. Entonces, tenemos que ir avanzando en ello y con un promedio de 4,7 años de acreditación. Otro dato importante en formación es las enfermeras tituladas por 100.000 habitantes, que este es el dato 2013 que salió publicado en el Health to Glance 2015. Y aquí en el centro, me voy a permitir leerlo de acá porque no tengo muy buena vista, si me disculpan. Acá. Si ustedes ven ahí, en la barra roja está la recomendación de la OECD que recomienda 47 enfermeras tituladas por 100.000 habitantes. Y Chile aparece con una cantidad de 53 enfermeras tituladas por 1.000 habitantes. Pero ese 53 no es personal de enfermería. Ahí están 2 niveles de enfermería que existen en mi país. Los técnicos de nivel superior, que constituyen los 2/3 de esa cifra, y 1/3 son las enfermeras y enfermeros que tienen el grado de licenciatura. Es por eso que ahí aparece una corrección en rojo, y la realidad es que nosotros tenemos una cifra mucho menor de la recomendada de tituladas, de enfermeras licenciadas tituladas. Estamos en 17,6 por 100.000 habitantes. O sea, la cifra va mucho más a la derecha, está como ahí lo indica el gráfico. Otros indicadores importantes de efectividad en el proceso de enseñanza-aprendizaje son las tasas de retención de estudiantes y de titulación oportuna. Estas dos figuras que hay ahí muestran la realidad de las universidades en Chile. Ahí están descritas la cantidad, la proporción, ¿no es cierto?, de estudiantes en el gráfico del lado izquierdo, la proporción de estudiantes que se retiene en primer año en las universidades. Y yo lo puse porque en nuestra carrera es muy similar. Nosotros tenemos buenas tasas de retención en primer año. Anda por ahí entre el 90, un poquito más del 90% de retención. Estaríamos como en el medio del esquema y coincide un poquito con los años de acreditación para las universidades. Y en el lado derecho están la tasa de titulación oportuna. Y ahí estamos mal. Nos demoramos mucho en titular a nuestros estudiantes, tenemos bajas tasas de titulación. Es una realidad para enfermería como lo es para nuestras universidades. La titulación oportuna es un indicador que mide los años, o sea, que el estudiante se titule en los años que dura la carrera, exactamente, no más de eso. Aquí, para pasar a la experiencia chilena, tenemos algunos datos de Chile. Tenemos una superficie larga y angosta de 756.600 kilómetros aproximadamente. Tenemos una división político-administrativa que considera 15 unidades geográficas o regiones. Nos dividimos en regiones. El año 2004 la población de Chile se estimaba en alrededor de 17.800.000 habitantes, que es más o menos la cantidad de habitantes que hay aquí en la Ciudad de México, en una esperanza de vida promedio de 80 años. Y nosotros, algunos datos de morbilidad, ¿no es cierto? Chile se ubica entre los 5 países de la OCDE con mayor prevalencia de diabetes y en 6º puesto en los datos con mayor obesidad. En Chile, la proporción de medicamentos genéricos en el mercado representa apenas el 30%, muy lejos del 75% que alcanzan países como Alemania y el Reino Unido, que es lo que se recomienda. Se ubica también, junto a México y Corea, entre los países de la OCDE con mayor gasto de bolsillo en salud, 4,6% versus 2,6% que es su recomendación. También decirles que estos gráficos muestran que tenemos una proporción de aquí se muestra la proporción de médicos en el gráfico superior que están ejerciendo entre el periodo 2000 al 2013. Si nos fijamos en el dato 2013 que está ahí marcado con rojo, tenemos una baja proporción de médicos en relación a la recomendación que está en la barra roja. Abajo está la recomendación para enfermería, se hizo la corrección, también tenemos una baja proporción de enfermeras licenciadas que estén ejerciendo en nuestro país. Entonces esto nos hace analizar el contexto y decimos, claro, tenemos en Chile una baja proporción de médicos ejerciendo, una baja proporción de enfermeras ejerciendo y más aún, tenemos escasez de médicos especialistas, que esto importa para la enfermería de práctica avanzada. Y tenemos un predominio de esas enfermeras que hay, que predominan enfermeras generalistas. Entonces aquí es donde está la oportunidad para el desarrollo de este proyecto, ¿no es cierto? Ups. Hay dificultad en el acceso y en la cobertura de la atención de salud. Eso hace que nosotros estemos como en la posición de poder responder con el desarrollo de estos nuevos roles de enfermeras y enfermeros como es la práctica avanzada. Y con eso, como ya se sabe y la literatura lo respalda ampliamente por la experiencia que hay en Canadá, que ha habido en Estados Unidos y que está muy bien evidenciada y documentada, sabemos que con eso podemos mejorar el acceso a los servicios de salud, disminuir los tiempos de espera, mejorar la satisfacción de los usuarios y, por supuesto, como lo acaba de decir la expositora anterior, reducir los costos de la atención. ¿Cuáles han sido nuestros primeros pasos? Lo primero, partimos en abril 2015 en que fue invitada una escuela miembro de nuestra asociación, la Universidad de los Andes, fue invitada a una reunión en McMaster University. Y fue muy productivo porque esa persona, que era la directora en esa época, hoy día es la decana, Consuelo, que está por ahí, Consuelo Cerón, fue en julio del 2015 a una reunión de nuestra asociación como miembro que es, y nos dijo, trabajemos en esto. Presentó lo que era el proyecto de enfermería de práctica avanzada, lo que la OPS estaba impulsando en todos los países y nos dijo, trabajémoslo juntas, esto no se puede hacer solo, y fue muy visionaria, nosotros también muy visionarios como consejo asesor, varias directoras de escuela, dijimos sí, esto hay que hacerlo, esto es bueno para el país, esto puede ayudar a nuestros pacientes y formamos en un tiempo siguiente lo que se llama la Red de Enfermería de Práctica Avanzada para la APS en Chile. Y esta red está constituida por 11 escuelas que voluntariamente, que pertenecen a Chile y que voluntariamente solicitaron participar en este proyecto. Y eso está relacionado también con el desarrollo que tienen estas escuelas. Eso fue en julio del 2015. Ya en marzo del 2016 hicimos algo muy importante para nosotros, muy marcador, que organizamos en conjunto a Chillén y en conjunto con la Escuela de Enfermería de la Universidad de los Andes el primer simposio de enfermería de práctica avanzada. Y fue vital porque ahí pusimos el tema sobre la mesa, ahí pudimos nosotros explicar de qué se trata, porque había muchos pares que no sabían de qué estábamos hablando. No era un tema que estaba en la difusión y en la discusión en ese momento. Asistieron 50 enfermeras representantes de centros de salud familiar que trabajan en atención primaria, también asistieron académicos, tuvimos invitados y invitadas internacionales, estuvo Silvia Cassiani con nosotros, fue con un asesor de OPS, estuvo el representante de OPS en Chile, que dieron el inicio al simposio, y se hizo un trabajo muy importante de grupo. Elaboramos un reporte, un informe, donde damos cuenta de todo lo que se trató en ese tema y también sirvió para vincular para fortalecer esta red que recién se había formado. Eso nos consideramos muy importante. El reporte lo tenemos en la página web de nuestra asociación y también lo distribuimos por vía electrónica a todos los agentes claves, tomadores de decisiones y por supuesto que participan en la atención primaria en nuestro país. No solo enfermeras, sino que también médicos y autoridades de salud. Y lo otro que es importante que quiero recalcar, que en abril del 2016 nos invitaron como asociación a la reunión en la Universidad de Michigan. Entonces, como ven ustedes, aquí hay dos centros colaboradores como McMaster y la Universidad de Michigan, apoyados por OPS, que nos invitaron a participar. Y eso fue muy vital porque nos transmitieron su experiencia, parte de ella la he escuchado aquí, y eso fue también vital para nosotros para poder imbuirnos mejor, empoderarnos mejor del tema y poder difundirlo en nuestro país. Aquí tenemos algunas fotos, esa fue la foto oficial del evento, del simposio. Aquí aparece el reporte y aquí trajimos algunas copias por si a alguno de ustedes les interesa conocerlo. Nosotros vamos a replicar este simposio porque ustedes comprenderán que no cubrimos a todo nuestro país y ya tenemos planificada la réplica. Vamos a hacer otros dos simposios iguales a este que está reportado, uno en el sur de Chile, en la Universidad de la Frontera, y otro en el norte de Chile, en la Universidad de Antofagasta, con la idea de difundir, de seguir contando qué es lo que estamos haciendo con este proyecto. También es importante que la sociedad se informe. Y aquí les traje dos cartas de opinión realizadas por nuestras colegas, en el cual siguieron una temática. En nuestro país siempre se están publicando las ineficiencias del sistema de salud en los diarios. Estas dos cartas de opinión están publicadas en el diario El Mercurio, y la tercera, que en mi país tienen bastante circulación, y ellas tomaron las problemáticas de las eficiencias en la atención de salud que hay en nuestro país como para difundir que el papel que podría ejercer la enfermera de práctica avanzada en solucionarlo, porque estos problemas de atención hospitalaria, de atención de urgencia, se pueden solucionar si la atención primaria funciona bien, si hay acceso y cobertura universal en la atención primaria, porque habría mucho menos recarga en estos servicios de salud. Así que, y con esto ya estoy finalizando. Bueno, 4 consideraciones finales, reflexiones. Primero, o recomendaciones para quienes quieran seguir nuestros pasos. Aprender de la experiencia de otros. O sea, fue muy importante hacernos el espacio y asistir a estas reuniones internacionales porque conocimos la experiencia de quienes tienen más de 50 años en el desarrollo de este proyecto. Entonces, es importante saber cómo lo hicieron, qué fue primero, qué fue después, como para poder seguir sus pasos o hacerlo mejor, ¿por qué no? Trabajar con las fortalezas que tenemos. La asociación que yo dirijo, y lo digo de verdad, y no lo digo con soberbia, lo digo porque creo que es una gran fortaleza que tiene nuestro país. Trabajar en redes, trabajar con todas las organizaciones de enfermería en el país, en todos los proyectos, en los proyectos de nuestra asociación y en los proyectos que tienen las otras organizaciones. Nos vamos respaldando mutuamente. Yo creo que también es una gran fortaleza. Realizar los simposios EPA, como le dije, a lo largo del país para develar el tema con todos nuestros pares y con las autoridades de las regiones que tienen poder en la toma de decisiones sobre atención primaria en salud. Aprovechar todas las oportunidades para difundir el tema con agentes clave, en reuniones con congresistas, con ministros de salud, insertarlo en proyectos, en cartas de opinión en los diarios. No crean que para nosotros es fácil, no ha sido fácil. Yo creo que nos falta difundir más, yo hago una autocrítica, nos falta más, pero en eso estamos trabajando y a raíz del desarrollo de otros proyectos como los que les mencioné, nos ha tocado hablarles, uno aprovecha de hablarle a los congresistas de por qué la enfermera podría también aportar a la salud a través de este nuevo rol en atención primaria. Bien, con eso termino. Muchísimas gracias.
Sí, muchas gracias a la maestra Soto. Y bueno, ya nada más finalmente hacer algo muy breve en donde, bueno, nuestros 4 ponentes coinciden en que la práctica avanzada, ¿no? Se requieren competencias específicas, sobre todo competencias clínicas, de toma de decisiones, de liderazgo, que se requiere de un grado académico, de un sustento también académico, una formación específica de grado de maestría mínimo. Y bueno, también coincidiendo en esto con la doctora Cassiani y Lauren Kelly, en algún artículo que ellos escribieron, pues esto implica retos para todos. la necesidad de ampliar la formación en posgrado en todos los países, los cambios en los sistemas de salud que han hecho referencia nuestros ponentes como algo esencial, el desarrollo, decía, de capacidades de liderazgo, pero sobre todo también de los cambios en las políticas y la intención, ¿no?, política de apoyar la formación de enfermeras en práctica avanzada. Asimismo, también tomar en cuenta la contribución, como lo estamos haciendo ahora, de países como Estados Unidos, como Canadá, que han tenido ya un importante avance de muchos años. En el caso de Estados Unidos, nos decían desde los años 50 y a la fecha, en Canadá también desde los 70s, 80s, en Chile recientemente, pero que esta experiencia reciente de Chile también nos invita a los países que estamos apenas haciendo nuestros propios análisis, ¿no?, de nuestro contexto, que también es algo importante, seguir esos pasos, ¿sí?, que nos ha planteado la maestra Paz Soto. Entonces, bueno, esto, la enfermera en práctica avanzada, la formación, consideramos como una estrategia de la OPS que están en el camino correcto. Hay iniciativas muy claras, existen entonces una política al respecto para todos los países de Latinoamérica y del Caribe, para que avancemos al respecto. Entonces, esta estrategia nos llevará seguramente al fortalecimiento de la atención primaria y, por obvias razones, a la cobertura universal de salud. Entonces, una invitación a todos los países, ¿verdad?, para que lo hagamos, nos sentemos, así como lo está haciendo Chile, a hacer una reflexión de cómo está nuestro contexto a nivel nacional en la formación de recursos. Y esa será seguramente lo que nos vendrá a dar una orientación futura en la formación de los futuros profesionales de enfermería en todos nuestros países. Y obviamente hacia este anhelo, ¿no?, que tenemos de mejorar la salud de nuestros pueblos. Entonces, muchísimas gracias. Yo agradezco infinitamente la participación espléndida de nuestras 4 ponentes esta tarde, el que nos hayan enriquecido, ¿no?, nuestro marco referencial, que nos hayan externado sus experiencias y que les aseguro serán de muchísima utilidad para todos nosotros. Muy amables, entonces procederemos. Muchas gracias. Procedemos a dar una constancia de agradecimiento a la doctora Denise Bryan. Muchas gracias, Denise. También nuestro agradecimiento especial a la doctora Josh Pulsini. Gracias, doctora. A la doctora Adelais Marcaqui. Gracias. Gracias. Bien, y finalmente a la maestra Eugenia Soto Fuentes. Gracias. Gracias a ti. Bueno, despedimos a nuestros conferencistas con un aplauso y gracias por su colaboración para este coloquio panamericano de investigación en enfermería. Gracias por estar en nuestro país también. Sí. Muchas gracias.